We'll start. Good afternoon. It's my pleasant duty to welcome you all to the third session, most important session on tertiary healthcare facilities with focus on trauma systems, current status and lesson learned. I also take this opportunity to welcome my chairperson, other chairperson, Professor Aung Myowin from Myanmar, and Professor Pankaj Patel from Ahmedabad. In this session, we have 4 speakers plus another speakers who from Singapore. So with this few words, now I request Professor Myowin to introduce our first speaker, Dr. Gerard.
Good evening, everybody. The session was started by the talk from Dr. Gerard Ole. He's an emergency physician and international operations manager at Africa Emergency and Trauma Center. Gerard Ole works as an emergency physician at the Prefect and coordinates the international programs for the emergency and trauma care. He also has a substantial experience in providing trauma services and medical support in developing countries, including Afghanistan, Kenya, East Timor, and post-tsunami Indonesia. Since 2004, he has coordinated trauma capacity building programs and trauma system consultancy in Kerala and Punjab, India, in addition to Sri Lanka and China. He has strong international working relationships with key trauma care and trauma quality improvement stakeholders, including the World Health Organization. So, may I invite Dr. Ole for the presentation.
Thank you very much, Professor Aung. Thank you to Professor Misra for the opportunity to come across and be part of this fantastic ASEAN East Asian Summit on trauma. And thank you to all of those who have supported us and some great friends and colleagues and to all honoured guests and people who are about to have to listen to me about trauma data. Trauma data is important. This is pretty low on data, but it is a call for the role of the trauma registry in improving trauma care. And from what we saw from the talks that have been given, or the presentations and discussions so far, is that many of them, and those that we noticed mostly, had some very simple data on epidemiology, on the burden of care, on what can be achieved if care is improved, and how outcomes have responded to various changes. For example, the Canadian example we heard just before lunch from Dr. Joshapura. So data is very, very important for many reasons, and I'm going to largely talk about why it's important, what the trauma registry is, give some examples of where it's been seen in various, what we might call very under-resourced settings, and what's involved, and then a call to arms, if you like, for a trauma registry wherever you're working across Southeast Asia. So many of you will be familiar with this. Australia, although its land size is similar to India's, is a very different country in many ways. We both play cricket, that's the other similarity, sometimes very poorly. Us against England, mostly. The population of 6 million, which is, so it's very sparsely populated, 6 million in Victoria, which is the state I'm from. So it's a small state in the southeast corner there, which of the states of Australia is actually the most densely populated, and most of that population of 6 million is in the city of Melbourne, the second biggest city in the country, 4 million. Who's been to Melbourne before? Okay, that's the interactive component of my talk. There's no incorrect answer. So the Alfred Hospital where I work, a little bit of background of where I'm coming from, is the largest trauma service in Australia. It's got a strong commitment to research and teaching, and the Victorian state trauma system that we'll see, both myself and Moira tomorrow will mention this, was made up of some 15 years ago, 17 years ago, crystallised into 2 adult trauma centres and 1 paediatric trauma centre. And so the one that takes the greatest number of trauma patients across the country is the Alfred, which I have the joy of working at, and that's why I'm here. Why I'm also here, I guess, is that I've also had a great privilege personally in being involved with lots of international trauma capacity development programs in various places. Me personally and other people who have been working in the National Trauma Research Institute, which is a component of the Alfred Trauma Service. And we've had great joy in being able to work in India, in Myanmar, and with my friends who are here today, in Sri Lanka, and in Philippines, China, and to a lesser extent in Vietnam. So to some level involved with some trauma system capacity development, and sometimes around trauma registries. And in India, particularly with the Australia-India Trauma Systems Collaboration, we've had a huge opportunity for relationship and collaboration with mutual learning about many aspects of what makes a trauma system work. Because we're looking retrospectively on the system I work in, and we're looking forward perhaps on systems that are so desperately in need to reduce the burden of injury. So I talk of friends and the importance of friendships, collaborations and relationships. So this is a very large collaboration. You'll see some familiar faces there, and that was a visit I think in July of this year by the contingent coming from AIIMS, GTB, Sion in Mumbai and in Ahmedabad, and the Prehospital service, Emory, that we're going to hear about also, EMRI. So, and that was an opportunity to really discuss some aspects of this program. And I mention this program because it does capture it tries to capture and tries to measure what the benefits might be of things, of what is a trauma system. And a trauma care system might, for example, include pre-hospital notification so we can all get ready with a trauma team. Or it might include the ability to have some remote telemedicine or some protocols that can be delivered to all hospitals, large or small. Or it might be about having a structured trauma quality improvement program. Or it might be about the importance of improving rehabilitation where there is none or little structured rehabilitation. Whether it's about any of these things or all of them, or things that aren't being studied, and they are the 4 interventions that are being studied as part of this project, there's no way of actually knowing unless you collect data. It's all useless. It's all anecdote, and it's all hypothesis and fantasy unless we're able to collect data before, during and after such and such intervention to see if these systems work. And there's no point someone from my neck of the woods saying that what we do in a high-resourced environment in a sparsely populated country is going to work where traffic is completely different, where we have 2 types of vehicles, really, really big rude cars and other cars that aren't so rude, and that's our 2 types of traffic. And coming here and saying that you should have the same situation. So we need a trauma registry to see, is this appropriate for India? And they're the 4 interventions summarised. So I'm privileged, and I've had no role in reducing, well, I don't think I have, in reducing trauma deaths in Victoria, particularly for the first 10 to 15 years of the trauma system. So, yes, as Professor Mishra was saying earlier, there was a huge intent to reduce death from injury back in the 1970s. Victoria was one of the first states in the world to introduce compulsory seatbelt legislation, followed not too long after by helmet wearing, followed not too long after by what we call the booze bus, which is the alcohol and now drug testing. And it's really only in 2001, so sometime later, I think even in the Quebec system, that Victoria embraced a system of trauma care. So it's been now 14, 15 years. And why was that? In 1999, it was determined, and these will all ring a bell in every country that's been looking at its trauma service or emergency service. These things will all ring a bell. Delays in ambulance response, delays at the scene by ambulance, delays in the transport, which would be a big challenge in congested traffic environments, inadequate medical escort and support, junior staff looking after the sickest patients in the emergency department, delay to CT, to X-ray, delay to the operating theatre, and not managing or preventing complications. So this list is nothing new. The US had learnt this 20 to 30 years ago. Canadians maybe 20 years ago. We learnt it 15 years ago. And for some reason at that time there was bilateral government support, so we were able to enact some things. And it was all about the pre-hospital system of the right patient to the right people in the right time. Did it work? Well, we're fortunate in retrospect that the Victorian state trauma system has been able to demonstrate a reduction in mortality over time, a reduction in risk-adjusted mortality over time, so adjusted for injury severity. That has to be collected as data to be out from the outset to measure that. A reduction, I've included Charlie's there because we also know there's the reduction, Charlie Mock's paper that Dr. Joshua Pura mentioned about the difference between highly resourced and less resourced systems in terms of mortality. And what we also know from the Victorian system was that there was a reduction in disability measured by 6 months post-discharge Glasgow outcome score. This requires data. And so by having data, Victoria is lucky enough to say that over this 9 to 10 year period, there was a 1/2 reduction in the odds of death, risk-adjusted death. As a result of all the aspects of this system, it's very difficult to know which ones were which. So what works? Sure, physical and human resources are important, but it's often those processes, again, that Dr. Joshua Pura spoke to, protocols, triage, communications, trauma team, and a trauma quality improvement program that is informed by a trauma registry, I think is paramount. You cannot improve care or even realise that you've improved care if you don't have a trauma quality improvement program informed by a trauma registry. So this is the quality improvement cycle out of the WHO guidelines on trauma quality improvement programs. And what is particularly important and often not done in my setting and others is that we don't analyse the problem, we don't identify the issue, we don't identify the corrective actions, and we don't follow up that deaths have been reduced. And to do that, we need data. We need all of these things, but data is one of the things that you'll see on this slide. So this was from Ron Mayer about what the essential attributes are of a trauma quality improvement program, and they include hard data, data collection must be ongoing. And there are many others about the meetings, but we need data. So a trauma registry is a key component of a trauma system. A trauma registry documents acute care, not just injury surveillance, but care that's delivered to injured patients. We need it. It allows us to benchmark and show improvement, and it informs just the weekly or monthly trauma quality improvement program that we ought have in any trauma system. And we can measure very simple things. These are very simple graphs from Victorian State Trauma Registry, and looking at numbers of patients, looking at the burden, looking at death rates, looking at injury severity, which is really important for benchmarking, looking what the transfer status was and what happened to the patient when they left, and comparing observed versus expected deaths, because that's what matters. So we heard a little bit about the situation in Thailand, and it was mentioned also of the Khon Kaen hospital system or regional system. So this is not, a trauma registry is not something that's peculiar, as you know, to Victoria in Australia, or to the US, or to Canada, or in fact to the UK. A trauma registry is accessible in all parts of the world. It is something that can be done for every trauma system. This is Margaret Chan with Professor Wataya Panchachai, who was a great leader of developing the system of trauma care, I think, at Khon Kaen Hospital in Thailand. And what the trauma registry was used to do in the 1990s for him was